Hello, I'm Victoria Delgado. I'm from Leiden, the Netherlands, and I'm here at EuroEcho Imaging 2017 in Lisbon with Professor Philippe Pibarot from Laval University. He's a known expert in the field of aortic stenosis and patient prosthesis mismatch. Welcome, Philippe. Thank you very much for
Thank you,
coming
Victoria.
here.
Very happy to be here.
What do you think that has changed the management of the aortic stenosis patients? How imaging has changed that evaluation of those patients?
Well, you know, Victoria, when I started my career, the assessment and management of aortic stenosis was used to be simple and straightforward. You know, when the patient developed high gradient, it was severe aortic stenosis, and then if the patient had symptoms, you needed to operate, and there was only one option: surgical aortic valve replacement, and that's it. And if you look at the other option, which was medical therapy with symptomatic severe EAS, from what we learned from Brownvald, you would have a very poor outcome with high gradient and symptoms. However, nowadays the population has changed. You know, it's more elderly population with more comorbidities, and there are many different types of aortic stenosis that we see nowadays. Patients with low gradient AS, for example, where it's a difficult and challenging situation where you have a discordance between the gradient and the valve area, and you have to determine if the stenosis is severe or not, especially if the patient is symptomatic, because if the patient is symptomatic and has a severe stenosis, you need to refer to intervention. And this is where multimodality imaging has really plays an important role. Of course, Doppler echocardiography remains the primary imaging modality for the assessment and management of aortic stenosis, but in some patients, especially those with low gradient AS, we can use dobutamine stress echocardiography, especially those with reduced ejection fraction. And in patients with low gradient and preserved LV ejection fraction, the so-called paradoxical low flow low gradient or normal flow low gradient, then as recommended in the most recent guidelines of the ESC, we should use a multi-parameter, multi-modality approach. One of the parameters that is very important and takes more and more place in the practice is the calcium scoring by CT it's maybe like a safeguard, you know, in this assessment of low gradient AS when you have uncertainty between a true severe that may require intervention versus a non-severe AS. The quantitation of the calcium score by MDCT may really be helpful. And this is, of course, just one of the parameters. And it's not a panacea, but that's an additional parameter that we can use. So I think it's really multimodality imaging is important. And in terms of future perspective, probably a cardiac magnetic resonance and the assessment of myocardial fibrosis may play a role. For now, it's still a research tool, but maybe in the future we're going to use this new parameter to enhance restratification and better define the timing for intervention.
That I agree, and I think that one of the treatments that has changed also the evaluation of these patients is transcatheter aortic valve implantation, TAVI, because for those patients we have seen that CT, computed tomography, plays a major role in those patients, and also, for example, TAVI is being expanded to other populations that were not suitable for surgery or were not indicated for surgery. For example, there is the TAVR and LOAD trial that will be for patients with moderate aortic stenosis and heart failure. So in these patients that sometimes it's difficult to diagnose if it's true severe aortic stenosis or they have moderate aortic stenosis, do you think that CT there will play a major role in order to derive these patients to TAVR?
Absolutely. I think, you know, well, TAVI clearly has revolutionized the world of aortic stenosis. Because before, many patients who had eventually an indication for valve replacement were not treated because they were considered too high risk. And First, in the initial experience of TAVI, we focused on the patients who are at extreme risk, and then we moved to the high surgical risk population, intermediate risk, and nowadays the trial that we have ongoing are on the low risk population. And also, as you mentioned, there are new potential indication, new population that we are looking at, and the two main ones are on one side the patients with asymptomatic severe aortic stenosis that are addressed by the early TAVR trial in particular. And the other is the patients with moderate AS and heart failure symptoms and depressed LV ejection fraction. And this is a very challenging population. We see those patients in the heart failure clinics. They come back every 2 or 3 weeks with heart failure symptoms, and the medical therapy has been optimized, and they are still feeling not well because they have this stenosis, this moderate aortic stenosis. And of course, it is very important to confirm that it is a true moderate aortic stenosis, and that's really the patients who are addressed by the TAVR unknown population. And CT, again, as in low gradient population, may be very helpful to confirm the stenosis severity, as well as, again, double-timing stress echocardiography.
I mentioned as well the role of cardiac magnetic resonance and the evaluation of fibrosis. There are some data coming up that these patients maybe have a worse outcome when they have already fibrosis because it's a change of the left ventricle that cannot be recovered. Do you think that in patients with asymptomatic aortic stenosis, maybe performing an MRI with late gadolinium enhancement to see whether there are already these changes may be helpful to decide which patient we will send for surgery or for aortic valve replacement?
Yeah, I agree. I think in patients with asymptomatic severe AS, of course, the concern that we have is that subclinical myocardial fibrosis and dysfunction may develop insidiously, and then even if you operate later and you have a successful surgical or transcatheter valve replacement, well, the patient may not get back to baseline, and it may have persistent LV dysfunction and eventually heart failure. So I think here really CMR and the assessment of the extracellular volume of myocardial fibrosis, and especially also the localization of the myocardial fibrosis, the presence of fibrosis in the mid-wall region, which is more specific to the aortic stenosis, may be really helpful to identify those patients among the asymptomatic severe AS who should be referred earlier to intervention versus those where you can do a watchful waiting or clinical surveillance strategy. I think it's going to be, among maybe other things like the blood biomarkers and some surrogate marker of myocardial fibrosis, such as the global longitudinal strain that we can now measure by specker tracking, might be helpful because certainly not all patients will benefit from earlier intervention. So we have really to individualize the strategy. And again, here, imaging and multimodality imaging may help to identify the patients who are at high risk to develop heart failure and potentially irreversible dysfunction and will need to be referred early to intervention.
I really thank very much Professor Pibarot for his time and this excellent discussion that we have had. Stay tuned and enjoy the Congress.